Good day, I am Micaela Grace L. Furigay. From BSN 2109, I am going to perform Leopold's maneuver procedure. So the first step is to wash hands to deter the spread of microorganisms. Assuming that I'm performing hand washing. Next is to explain the procedure to the patient to gain cooperation. So ma'am, I am going to perform the Leopold's maneuver procedure to determine the fetus presentation and promotion. Next is to let the patient empty her bladder, deviate before the procedure. Position the patient on supine with one pillow under her head and with knees slightly flexed. This is to facilitate accurate assessment, providing comfort, and flexed knees relieve tension of abdominal muscle. So, kindly question, ma'am. So, ma'am, have you emptied your bladder? Okay, so if right-handed, stand at the woman's right facing the patient. This is for better accessibility of the healthcare provider. Then now I am going to proceed with the first maneuver or the fundal grip. So face the patient and palpate the uterine fundus to determine what part of the fetus lies in the upper part of the fundus. So the head feels hard and round, freely movable and ballotable, and the beach feels large, nodular, and softer. Okay. Okay, so this part feels large, nodular, and soft, which means that this is the breech part. Okay, so now I will do the second maneuver or the umbilical grip. So palpate in a downward direction on the sides of the abdomen, applying gentle but deep pressure to determine the position of the fetal extremities, fetal back, and anterior shoulders. On the side of the fetal back, a long continuous structure will be felt, and the side of the extremities will feel nodular. Okay, so I can feel a long continuous structure on the right side, which means that it is the side of the fetal back. The left side, on the other hand, feels nodular, so that means that it is where the extremities of the baby is located. Next is the third maneuver or the Pollock's grip. So place one hand over the diaphysis pubis and grasp the lower uterine segment between the thumb and fingers to feel the presenting part. If engagement has occurred, fetal part feels fixed in the pelvis. The head is at inlet or in pelvis. In presenting part is still movable, so it is not engaged. Okay, so the fetal part feels fixed in the pelvis, which means that engagement has already occurred. So for the last maneuver, which is the fourth maneuver or the pelvic grip, turn and face the woman's feet to confirm the findings of the third maneuver and determine the flexion of the fetus head into the pelvis. So the cephalic prominence is felt on side where there is greater resistance to the descent of the vertex. Okay, so the cephalic prominence is felt on this part opposite to the side of the back. So next is to locate again the back of the fetus and place the stethoscope over it and listen to the fetal heart tone for 1 full minute. Then note the location, rate, and character of the fetal heart tone. So the normal fetal heart tone is 120 to 160 beats per minute. This is done to monitor and evaluate the condition of the fetus. And as we located earlier, the fetus back is in the right side of the mother's abdomen. Okay, so the fetal heart tone is 125 beats per minute. Then, next is to make the patient comfortable to provide comfort to the client. Straighten na, straighten your legs na. Then, wash hands to prevent the spread of infection. And last is to document the observation made, fetal findings, the presentation, position, attitude, and whether engaged or floating to have baseline data for future use. That ends the Leupold maneuvers procedure. Okay, so the next procedure is taking fetal heart tone using the stethoscope. So first is to wash hands to avoid the spread of microorganisms. Okay, next is to explain the procedure to the client, as listening to the baby's heart rate is a routine assessment periodically to check the baby's condition. Okay, so ma'am, I am going to take the fetal heart tone using the stethoscope to assess the health status of the fetus. Okay, next is to find a quiet location to provide comfort to the patient. Then let the client lie down on a soft surface and expose her abdomen for easy accessibility to the client's abdomen of the healthcare provider. So next is to feel the client's stomach and try to locate the baby's back. The midline is generally a good place to locate the fetal heart sound. So from the previous procedure, the fetal back was already located at the right side of the mother's abdomen. So next is to place the earpiece of the stethoscope in your ears and the chest piece along the baby's back to provide accurate findings. Then listen carefully for a few minutes through the earpiece. And in case that I do not hear the baby's heartbeat, slowly move the stethoscope up or down until I will be able to pick up a sound. Moving the stethoscope to several areas on the abdomen will help locate the loudest fetal heart sounds. Okay, so assuming that I have already counted the fetal heartbeats in 1 full minute, so the fetal heart tone is 125 beats per minute. Okay, so next is to make the patient uh, comfortable to provide comfort measures. Okay. Then next is to wash hands to avoid the spread of microorganisms. Then lastly is to document the date and time of assessment, the fetal heart rate and rhythm, any increases or decreases, maternal heart rate and rhythm, the device used, any actions taken as a result of my findings, and my patient teaching. Okay, so now I'll be doing the assisting in normal spontaneous delivery. So first is to ensure all delivery equipment and supplies are available and place of delivery is clean and warm. So the temperature of the room must be 25 degrees Celsius. And here are the equipments needed. So we have a cord clamp, straight forceps, surgical scissors, 2 hand towels, a bonnet, alcohol, 10 IU oxytocin, sterile gloves, kidney basin, and identification label. Then second is to ensure bladder is empty. Okay, ma'am, so have you emptied your bladder yet, ma'am? Okay. Next is to assist the woman into a comfortable position. Fourth, stay with her and offer her emotional and physical support. Allow her to push as she wishes with contractions. Wait until head visible and perineum distending. Then, five is to wash hands with clean water and soap. Put on gloves just before the delivery. Okay. So now, um, six is to keep one hand gently on the head. Okay. As it advances with contractions. Then, seven, support perineum. Okay, with other hand and cover anus with pad held in position by side of hand during delivery. 8. Leave the perineum visible between the thumb and the first finger. Then 9. Ask the mother to breathe steadily
and not to push during delivery of the head. Okay, so mommy, don't breathe steadily and do not push, okay? Then 10 is to feel gently around the uh, baby's neck. Okay, for the cord. Then, check if the face is clear of mucus and membranes. Then, 12, apply gentle downward pressure to deliver the top shoulder. Then, lift baby up towards the mother's abdomen to deliver uh, lower shoulder. Then, okay, baby out at 10 a.m. It's a girl. Congratulations. So, next is to place the baby on the mother's chest. Then 15 is to note the time of delivery. Then 16, thoroughly dry the baby immediately. Wipe the eyes, discard the wet cloth, and assess the baby's breathing while drying. Okay. Next, 17, palpate the mother's abdomen. Okay. Then 18, give 10 IU of oxytocin IM to the mother. Then watch for vaginal bleeding. Okay. Then 19, change gloves. If not possible, wash glove hands. Okay. Then 20 is to put cord clamp tightly around the cord at 2 centimeters and 5 centimeters from the baby's abdomen. Okay. So now 21, cut between ties with a sterile instrument. Okay. Then 22, observe for oozing blood. 23, leave baby on the mother's chest in skin-to-skin contact and place identification label. Then next is to cover the baby, cover the head with a bonnet. Okay. Then 25, encourage initiation of breastfeeding. So now we'll be delivering the placenta. Okay, so ensure that the 10 IU oxytocin has been given. Then place side of one hand, usually the left, above symphysis pubis with palm facing toward the mother's umbilicus. This applies counter traction to the uterus during controlled traction. At the same time, it applies steady, sustained, controlled cord traction. And next is, as the placenta is coming out, catch in both hands to prevent tearing of the membranes. And if the membranes do not slip out spontaneously, gently twist them into a rope, okay, um, and move them up and down to assist separation without tearing them. Okay. So I will place this placenta to the basin. 30 is to repeat check every 5 minutes. 31, examine perineum, lower vagina, and vulva for tears. Then 32, collect, estimate, and record blood loss throughout third stage and immediately afterwards. Then 33 is remove the gloves and perform hand washing. And so that ends the normal spontaneous delivery.